Hello, my name is Annie Rogers, and on behalf of the ADDitude team, I am pleased to welcome you to today's ADHD Experts presentation titled Understand How ADHD and Schizophrenia Overlap. Leading today's presentation is Dr. Napoleon Higgins. Dr. Higgins is a child, adolescent, and adult psychiatrist in Houston, Texas. He is the executive director of the Black Psychiatrists of America and CEO of Global Health Psychiatry. Dr. Higgins is an author and co-author of multiple books on ADHD, depression and grief, mental health in Black communities, and physician practice issues. He also specializes in nutrition and health to improve patients' well-being. Research shows that ADHD in childhood can increase the chances of developing schizophrenia later in life. At first glance, these two conditions might seem distinct and unrelated, but ADHD and schizophrenia share some similarities and risk factors, which we will discuss today. Dr. Higgins will also address barriers to care and treatment innovations. We'd like to begin today's webinar by asking a poll question to our live audience. Please tell us which of the following treatment protocols for ADHD and/or schizophrenia you are hoping to learn more about in today's webinar. Please select all applicable answers, and you can comment in the text box under the video player to tell us more and help guide our Q&A at the end of today's presentation. For answers to common webinar questions about slides, transcripts, and certificates of attendance, click on the FAQ tab of your webinar screen. ADDitude Magazine is the gift that keeps giving all year long. Visit additudemag.com/subscribe to take advantage of our 2-for-1 holiday offer and give 2 subscriptions to a loved one, educator, or yourself for the price of 1. Click the magazine tab on your screen to learn more. And to complement today's conversation, our new free download focuses on schizophrenia and its association with ADHD. You can check it out using the link on your screen or on our homepage at additudemag.com. So without any further ado, I am so pleased to welcome Dr. Napoleon Higgins. Dr. Higgins, thank you so much for joining us today and for leading this really important discussion.
Yes, thank you so much. And I want to thank ADDitude for bringing me here today to discuss a very interesting topic, understand how ADHD and schizophrenia overlap. I'm a psychiatrist here in the Houston, Texas area, child, adolescent, and adult psychiatrist. Oddly enough, I'm doing college mental health today at my alma mater, which is Prairie View A&M University in HBCU, northwest of the city of Houston. So it's, and really by being here kind of puts me in that age group where you have that gap between being a child and being an adult. And then you have these late adolescents and young adults on a concentrated area. So we'll go ahead and start moving forward. We have a lot to cover. Obviously, ADHD, schizophrenia, how are they similar? Because obviously people know how they're different. And we're going to look at these overlaps of why this is important. Now, honestly, I love to give an introduction and tell people how I got to do this talk. And I really don't remember. I remember mentioning it maybe about a year ago. And so the follow-up and then the follow-through, but something definitely interesting to hear about, because honestly, I don't think I've ever heard a talk that talks about the overlap between these two very important diagnoses. I'll need you to advance the slide here. There we go. I got it. So we're looking at this overview and the prevalence and societal impact. Understanding that when we think of ADHD, we think of children. When we think of schizophrenia, obviously we're tend to think about adults. But the fact is that you can have overlap and interplay between the two, because I've definitely seen kids, even though it's uncommon, I've seen children with schizophrenia, even young children. And then I've seen, obviously you've seen adults with ADHD, especially with the audience that we have here today. But the incidence of ADHD is about 10% in children, I've seen anywhere from 10 to 20%. So essentially 1 in 10, 1 in 20 kids. And about one, and with adults, it's about half of that. Now, the question becomes, why do adults have less ADHD than kids if kids are diagnosed with ADHD? And I would say that sometimes it could be adaptive, where adults possibly grew out of it, but more often than not, you're out of the classroom. And so the classroom is normally what pulls out symptoms of ADHD, realizing that the school is a pressure cooker, especially as you go from kindergarten all the way to the 12th grade. And the odd thing tell people about high school, especially in high school, it's the only place that you'll be in life where you have to be around a bunch of people that you may have no interest with outside of jail or prison. So that tells you the pressure cooker that a kid can have, especially when it comes to those children who are different or neurodiverse. And when I say neurodiverse, I don't know how much different that is, other than everybody is a little bit different than the rest of the crowd. But the fact is that this diagnosis can be very difficult to manage, even as ADHD. And of course, when we think about schizophrenia, we think of the impact that schizophrenia has on a person, an individual, and a family. And the fact is, schizophrenia only occurs in about 1 out of 1,000 young children, and I normally say about 1 in 100 adults. All right, 1 in 1,000, 1 in 500 kids, about 1 in 100 adults. Now, when you multiply that by, say, the United States, which is 300 million people, that means that there are several children who have schizophrenia, right? Because obviously 1 in 100 would be a lot of people who have schizophrenia as adults. So when you look at severity of illness and outcomes, you do not want to diagnose a child with schizophrenia. I prefer not. I'm always looking for something else for it to be. And then when it comes to diagnosing ADHD, essentially, I need most of the other diagnoses ruled out to get to the diagnosis of ADHD. And we'll cover a little bit of why that's important down the road. But with schizophrenia, you see a downward drift in how a person is acting in society, so far as the ability to get married, have a job, and all those things are greatly impacted. Get a driver's license and live on their own independently. Versus with ADHD, we're expected you should be able to do those things. But the other side of ADHD is you can also have the downward drift, where if you're as a child are getting in trouble, having problems in the classroom, maybe not performing up to your aptitude of what would be expected from your IQ, or even if you're starting to get in trouble out and then being pushed out of the classroom because of behavioral problems, then you start to be around other children with behavioral problems. And then at that point, you're looking at the risk of them possibly not graduating, on top of the issue of not being able to reach your top aptitude of what are your abilities and your desires. So these can be both serious illnesses. I've known people with schizophrenia who've done very well with their medications, who are really, on top of the world. And when I say that, refer so far as being able to get to all the things that they wanted to do in life. Be married, have kids, have a good job, have good income, and have a stable life. And then I've seen also people with ADHD who are very severe, where nothing seems to work very well for them. So when I say the severity of illness, obviously schizophrenia is seen as a more severe illness, but also ADHD is definitely impactful and can be severe as well. So ADHD versus schizophrenia, looking at several factors. So far as you tend to see ADHD diagnosed when you're about preschool or in school, because that's the first time the child is around adults who are trained in neurodevelopment. So it's a neurodevelopmental disorder with focus, attention, concentration, impulsivity that we see in childhood that in fact impacts your academic, occupational, and social functioning. Now with schizophrenia, the thing we think about with schizophrenia is hallucinations and delusions and bizarre behaviors, impaired emotions, and it tends to start late adolescence, or about 15 to 25 is the time that you start to see schizophrenia. But this is the thing you have to understand about schizophrenia. Schizophrenics will have all the symptoms, can have all the symptoms of ADHD, but the trump cards are going to be the hallucinations, paranoia, and odd behaviors that we see with schizophrenia. So hallucinations can occur in children, but more often than not, if you see a small kid with hallucinations, it's normally going to be fantasy or anxiety. All right. And if it's disturbing, fantasy is not disturbing. Anxiety is disturbing. right? Or the overlapping mood issues overlapping symptoms of autism or other mood disorders will be considered many times if you see a child with some of the behaviors of schizophrenia. And I tell people, children are like budding flowers. You don't know where all the petals will be until the flower's in full bloom. So as we see children growing and developing, we see more and more things come out. And typically, if you haven't had schizophrenia by the age of 25, 26, 27, it probably won't happen. ADHD, there is a thought that ADHD can occur later in life. Maybe it wasn't that early, but it can occur later in life. And many times I believe that life just gets faster. So essentially, my life was busy in middle school, but it was more busy in high school. College, you're having to adjust to all these other things going on so far as cleaning and washing clothes, as well as your regular academic appointments. But then you get out. Maybe there's grad school, but then you have, a spouse and children and having to take care of your parents because they're now elderly. All of life gets faster, and it can bring out and show you that, hey, maybe I'm not as organized as I thought I was, and possibly maybe I have ADHD that was never diagnosed. So what are the structural and biological differences? All right, I won't go deep into this because most of us on here are probably not clinicians, but we do have some. So the thought is that, with both ADHD and schizophrenia, the hallmark and main neurotransmitter we consider is going to be dopamine. All right, so you have your prefrontal cortex that is involved in cognition, thinking, decision making, and attention regulation. And because of the impairment in dopamine, you can have inattentiveness in both of these diagnoses. But when I think of ADHD, I think of reduced activity in the frontal lobes, impairment in the basal ganglia and cerebellum, so far as impulsivity, decision making. Sometimes it can affect emotions and decision making. But normally when I think of ADHD, I'm thinking of low dopamine. When I'm thinking of schizophrenia, typically I'm thinking that we have high dopamine or excessive dopamine in the brain, causing issues with hallucinations and hearing voices. Or I say this way, that schizophrenia is involved with dope, and that people are acting acting in a way that's odd behavior because of excessive dope in the brain. So the excessive functioning and working memory, the executive functioning and working memory can be an issue. Auditory processing and hearing voices, formulation of memory, the connections to emotions, where all of that's related and the dopamine is surging too high. So often when treating ADHD, we're trying to increase the amount of dopamine in the frontal lobe, but with schizophrenia, many times we're trying to decrease the amount of dopamine because elevated dopamine is thought to be high. And realizing these are all theories on how these medications work, how the treatment should go, understanding that there are a lot more factors. So I don't want to believe that you can simplify ADHD or schizophrenia to just this one slide. Obviously, there are people who spent their lives studying this. So barriers to proper diagnosis, misdiagnosis risk, especially when you're looking at, African-American patients or just patients who may be different. So you have ADHD is often misdiagnosed in African-Americans. And when I say that, I'm referring to the issue of, one, it's more likely to be overdiagnosed in African-Americans. That was a recent study that came out in 2020, I believe it was during the pandemic, that showed that white teachers, when they see Black males, they're more likely to believe that the child has ADHD. And then the parents who see the same child are less likely to believe that they have ADHD. And you can have this disconnect often between the school and the parent. Schizophrenia is overly diagnosed in African Americans. All right, overly diagnosed. We're overly represented in all schizophrenia studies. And the question is, why is that? Why do people believe that? And it's only in America where Black people have higher levels of schizophrenia. It's only in America where we see this. So the influence and overlapping symptoms, along with bias, impairs the ability to make the correct diagnosis and for families to believe the diagnosis is correct. That access challenges, so far as there's not enough mental health specialists. There are not enough psychiatrists, all right? And the government knows this, but the fact is that we're not making more psychiatrists as fast as the population is growing. So the dearth of psychiatrists, you do have other allied health, nurse practitioners, PAs, even some prescribing psychologists. But I know for myself, Holidays are coming up. People want to be seen. I know I'm taking off for Christmas and Christmas Eve, but the fact is that there are people who want to be seen, who need to be seen, and there are emergencies that are going on. These geographic and economic disparities, so far as rural patients in rural communities, where I'm from, which is outside the city of Houston, very rural community, you're having to drive. You're having to drive in. Telemedicine helps some of that because now I have patients as far as from Houston to El Paso. Especially down into the valleys of Texas, going closer towards Mexico. There's a dearth of actual people who can see you, especially for those who are trained specialists or even subspecialists, as I am myself. And then economic disparities, the ability to afford the treatment, afford the medications, afford to see the doctor, afford to take off time to see the doctor. All of those things hit. You do have your safety nets, and those are typically overrun. The net can't catch everybody because everybody simply cannot get in. And then the issue of insurance, which has been definitely on the news when you look at some of the major insurance companies, denial of coverage, denials for the newer medications, higher premiums, higher everything. And then also restriction of access to the latest treatments. Both affect ADHD and they affect schizophrenia, so far as the issue of being able to access the newest medications and the newest treatments. Understand that when it comes to being a doctor, I know a lot more information and I have a lot more options that I know to do. But the fact is that it's going to be limited by what I'm allowed to prescribe and what the patient, well, I can prescribe whatever I want to prescribe. But if the patient can't afford the treatment or afford the medication, or if the insurance denies the treatment, even though I know the latest, greatest thing, I will not be able to prescribe that. Now, we have a lot of risk when it comes to ADHD becoming schizophrenia. And so there are a lot of questions, a lot of pre-questions about what is the risk of this becoming schizophrenia. Realize and understand this. The greater majority of ADHD will never become schizophrenia. The greater majority. All right. Now, if you have, if when you're looking at kids, if you see that there's disruptive behavior, more often than not, because of where they are in their age and their behaviors, it gets diagnosed as ADHD, or it could be a very late term that's thrown around a lot because a kid is acting up or not behaving as we would expect or like. So maybe this child is ADHD. Now, when I see the kid, somebody asked me, hey, could you see this? Could you see somebody for an hour for free? All right. And I was like, well, what am I going to do in an hour? It takes me an hour just to figure out at least what's kind of going on with the person. And it may take a lot more time than that. So I don't know what I could do for a person in 1 hour, because the fact is that I've got to go through a whole host of things to just diagnose ADHD, not to mention having something as serious as schizophrenia. We got to definitely take our time. And part of that is making sure we get a good family history of what's going on with the patient. Because if I see a child at 6 or 7 years of age and the father is schizophrenic and the grandmother is schizophrenic, and there's other behaviors that we've seen in multiple generations, they have a cousin who's schizophrenic, first cousin who's schizophrenic, and the teenage older sister is starting to hear voices, and I'm looking at a 6, 7-year-old, my mind has to go towards maybe this is not just ADHD, maybe it's schizophrenia. But the fact is that you've got to go with what you see at the time with the individual. But you have to always have yourself in alert that it could be more than ADHD. We're looking at dopamine dysregulation, especially when you look at development. When dopamine dysregulation occurs in a child, we think ADHD. But when dopamine dysregulation happens in an adult, we may be thinking of something else or other diagnoses, because we typically don't apply adult diagnosis to kids. But the fact is that children are not as well studied as adults. So the diagnosis of childhood schizophrenia becomes tricky because kids are not being studied for that. So what does that look like in a child? And normally we don't know, even though we can say we're seeing behaviors that look like ADHD. And the fact is that ADHD treatments work over 97% of the time. 97% of the time. If nothing seems to be working, maybe we're dealing with some other issue outside of ADHD that may be going on with this child. Now, when you look at adverse child experiences and trauma, this is a serious issue, because I don't care who you are. If enough craziness happens in your life, and yes, you did hear a psychiatrist say crazy, because craziness can happen in your life that has nothing to do with you, but the craziness outside in the world. So be it physical assault, sexual assault, the younger you are, when those things happen, the more likely you are to have serious mental illness. And it's very hard to pick up trauma many times in kids because kids don't necessarily tell on adults. Now that I've been in practice over 20 years, I've had multiple adults who I saw as kids let me know that they were being sexually abused as a child, and I literally had no clue, or even physically abused, or whatever. I'm seeing two parents walk in with the kid. Maybe the kid was 10 years old. Now that kid is 30 years old, letting me know about what else was going on inside the home that I had no clue of when that child was 10. Now, one thing that I've seen a lot of questions about is I have on here, I say weed, and then I have in quotation marks, new weed. Now, why do I have that in quotation marks? This is my alma mater, Prairie View A&M University. Now, I call this 13th grade because we've been here for about 5 generations. My mom's family is right up the road. Now, the fact is that when I was in college, weed was a thing. Obviously, it's been around forever, since the dawn of man, as far as I know. But the potency of weed has greatly changed. So when I was in college in 1990, weed was about 1 to 2% THC. Now, weed, you can't find it less than 20% at this point. All right. So 1 to 2 joints when I was a kid is now equal to 10 to 20 joints. All right. That's with low potency weed. Mid is about 40% weed. All right. It's a 40% THC content. And then if you're using vape weed, it's about 60. And then if you're doing dab with butane and heating up oils, that could be 99% THC that a kid is smoking. We're basing research on what people smoked when I was in college. All right. It doesn't look the same. It doesn't smell the same. The high looks very different. All right. I remember the first time being around new weed, somebody had brownies and people started like having difficulty standing up, like holding onto the wall. And I'm like, I've never seen weed do that. And so essentially what I've seen in my own practice is that I'm now seeing with the legalization, even though it's not legal in Texas, with the legalization of weed, there's more of it. Now I'm starting to see more middle schoolers, 12 and 13-year-olds. I had a young man come in having a lot of difficulty, ADHD medications don't work. He's on a lot of other medications. Let's do a drug screen. And so we knew he was on marijuana. And then his mom found the vial. And so she, sent me a picture of it, looked it up. It turns out high potency weed, it's about 60% THC. Then, looking up how they put this together, because there's like one leaf. Now, when I was in school, weed looked like hay. Now weed looks like dark green broccoli. I don't know what that is. But anyway, so it looked like this piece of green bush, 6%. Not only was it 6% weed, it was dipped in weed, in weed oil. And then they had sprinkled the leaf with weed as well. And then you take your own and you cut it up and you roll it. At that point, I could tell the mom, I don't know what exactly he's smoking because it's high potency, dipped and sprinkled. And he's now psychotic in front of me. Now, I can't make the diagnosis of schizophrenia or ADHD because the fact is that this kid is extremely high, all right? Or he's very high, went off at school, had to be escorted out by the police while playing basketball. He got escorted and had to be taken out the building by the police at the time the kid was 12. So this is getting into younger and younger individuals. The other problem with youthfulness is that your brain is not fully developed. So we don't know what this new weed is doing in such young brains, but also doing in college mental health, I'm seeing weed in college students as well. And the amount that they're smoking. And I say, I don't know where they get the money from because I was broke in college. But these kids have a lot more money. So they're smoking a lot more of high potency. And when you look at the research, I was at a recent program about a year ago. It was a government study, and they were studying 7% weed. I'm like, nobody's smoking 7% weed. That's like the Chronic back when Dre came, Dr. Dre and the Chronic. All right. I don't know how many of y'all know music, Dr. Dre and the Chronic came out at about 94, 96. That was 8, 9% weed. Now we're looking at weed that is 60, and the studies are not being done. Alcohol use can increase the risk of worsening of mental health. Now we have the issue of cigarettes. And when I say cigarettes, I'm going to focus more on vaping nicotine, because now the oils are higher level concentrated. The dopamine and the high is a lot more. And what is this doing to the brain? We don't know when people are inhaling or vaping heated oils, and it's going straight into the brain. The fastest way to get a drug into the body is to inhale it, because your alveoli in the lungs is about 100 yards of actual one cell level thin cells. So the fact is that these other things are going on. Other things such as synthetic marijuana, other these salts that people are smoking. All this stuff is new, and we do know from in the past till now, and I believe it's getting worse, that this can induce schizophrenia and be further impairment on the brain. Also, with marijuana, it's also shown to decrease the thickness of your gray matter of the brain, which is the portion of your brain that actually controls decision making. All right. So you start to see more adolescent or more youthful type behavior, or I've seen people seem like they dropped a bit so far as their adult understanding of how the world is moving forward. So other issues, bullying, negative peer interactions. This happens in schools all the time. And for some reason, we've seemed like to give a go box for people to be able to say very negative things that were not previously said before, that are very disturbing. And then the kids can be threatened even after school. I had a young lady diagnosed ADHD, started having aggressive behavior on the school bus. Turns out that some kids were stealing from her, taking things from her. And if she had reported it, they were actually threatening to sexually assault her. Several males were threatening to do this, so she was afraid to tell anyone how she was being treated. Also, she was being called the N-word, things of that sort, and was very afraid because of the risk of retaliation. It's important that we do timely intervention to prevent these social drifts that can cause insult to the brain. So the fact is that with ADHD, you can have certain things, but then the fact is that if you put more and more stressful life events or more, I would say, impacts on the brain, the more likelihood that you can induce other things to come out of the individual. Other stressful life events such as divorce. We often forget that when in a home, kids are in the home as well. So if it impacts mom, if it impacts dad, or whoever else inside the home, it impacts the child. The problem is that the child cannot make the decisions that the adults can make. So they can't go, they can't leave. They have to be there for whatever else is going on inside the home. And I like to say that a child is like a rubber ducky in the bath. The adults are splashing around, but it's the child being bounced against the walls that no one seems to be paying attention to. Also look at the stress of academics. Imagine if you can't do academics right, then what can you do right as a child? Because that is what you do 8 hours out of the day. And there's always a complaint, you're not meeting the mark, and this can definitely stress a child out. So I always recommend with families, if you know your child is doing the best they could do, make sure that you're doing all that you could do to make sure that you can ensure the academic achievement, individual education plans. And also we need to focus on what the child does well, because there are things that they may be very good at, be it cooking, or they like to, ride bikes, or they like band, or they like football, they like cheerleading, whatever, crafts and all these other, nature. Push those things, because too often families forget those are actually careers. Those are real careers, that also can, take care of them for the rest of their lives. So making sure we pay attention to that. And then the issue of bereavement, loss of a parent, especially if the household income is, say, 150,000, one person was making 80, the other person is making 30, you lose the 80, that person, with 2 kids now is in poverty. So you went from middle class to poverty with the loss of one particular parent inside the home. And these can change your entire environment. There's always mistrust when it comes to diagnosis, especially in the Black community. The stigma of being diagnosed with ADHD and how we perceive that, because so often our children are diagnosed with ADHD. And so therefore, there's a downward drift that can occur with that. So I've seen mothers cry. I've only seen Black mothers cry when you diagnose ADHD. Now, obviously, if you're diagnosed with schizophrenia, there's a whole nother fear factor that goes into that. But these barriers to insurance and medications and therapy and training and interventions because of the lack of finances, geographical barriers that as we had already talked about, maybe the medication's not working well for us. Many of these medications have only been studied in certain part of the population and not others. So the issues of treatment resistance, maybe the medications aren't working, or family dynamics, especially if the family can't get to the appointment. You know, I tell families, if you're struggling, I need to see the child more often. But if mom and dad have jobs that they cannot get off of, or you have a single parent inside the home who has to work, who has multiple other kids, also with mental health issues, this could be tricky. And then the co-occurring disorders. If you go from ADHD as a child to schizophrenia not diagnosed as an adult, I can guarantee you we've got other mental health diagnoses that are falling in between. Not to also mention that we may have other medical issues, be it, you know, from autism all the way up to some other medical problem, mental or medical problem that all occurs within the diagnosis frame of everything in between ADHD to schizophrenia. This mistrust of the medical system is something real. You know, I am a Black man in America. I can tell you this much. I don't trust much of anything. If somebody tells me the sky is blue, I'm going to probably look out the window just to make sure. All right. Now, I can go through that at a different time, but it's just facts. And there's safety in that, in the paranoia. Trust me. So the mistrust of the medical system, so far as the wrong diagnosis, is something that often happens in communities, especially if a person doesn't understand the community or does not know the community. Treatments offered can often be different according to race. These overdiagnoses of both of these diagnoses in Black populations that it seems to occur in America and just about nowhere else, because you got Black people all over the planet. School intervention. Making sure that we understand that when schools and when a Black child is diagnosed with ADHD, they're more likely to be diagnosed with oppositional defiant disorder. They're more likely to be diagnosed with conduct disorder. When it comes to adult Black people, we're more likely to be diagnosed with schizophrenia. These populations of schizophrenia are only seen in Blacks in America. But when the intervention occurs, it's often the school police. With adults, when schizophrenia occurs, it's with incarceration. So the fact is that if you're a Black child with ADHD, you're more likely to end up in ISS, you're more likely to end up in alternative school, and you're more likely to end up outside of the school, which makes you less likely to graduate. And then when there's police intervention with Black adults with schizophrenia, you're more likely to see us get shot, more likely to see us get killed, more likely to see us get arrested. We're less likely to end up in a mental health facility and more likely to end up in a prison. And sadly, you saw the young man the other day. The verdict just came out where, both were, one was acquitted for murder and the other one is dead based upon his behavior. Now, I can guarantee you that if that was a Black man who choked out a white woman with schizophrenia on the subway, I doubt if it would have been the same verdict. So this high levels of incarceration can occur in both ADHD and schizophrenia, and this starts early in life, that a person who is Black with these issues are under risk of lockup and your life being changed more likely than others when you're diagnosed with both diagnoses. So diagnostic challenges. All right, there's an overlap in symptoms. The cognitive issues, so far as attention and executive functioning and memory, occur in both disorders of ADHD and schizophrenia. And the behavior similarities are similar in early development. And so now check this out. And let's look at diagnostic criteria when it comes to, say, the DSM, Diagnostical Statistical Manual, what is it? We're on 5, TR. Imagine as a child is born. I'm a child, adolescent, adult psychiatrist. Youngest kid I've ever seen is 2. The oldest adult I've ever seen is 103. As a child, if you start acting up in school before school starts, say around 2 or 3, and you're not connecting, attention issues, executive functioning problems, you're not communicating with the family, many times you may be diagnosed with autism. Now, by the time you hit school age at 5 to 7 or 8, many times if you start to see it at that point, somebody may call it ADHD. As you start to do a downward drift and you're struggling in school, many times a child may become anxious because they're not functioning well, maybe become depressed. Now, as you go into middle school and go into high school, this downward drift continues to occur. Maybe substance abuse starts to occur, irritability, anger, mood swings, not being able to understand what this kid is going to do from second to second, moment to moment, hanging around the wrong crowd, not sleeping, staying up, which is a cognitive, is a developmental issue that occurs in kids. Somebody may call that person bipolar disorder as they move into college and get away from the family and the home. Drug issues still going on, bipolar issues going on, social drift is going on. You're not maintaining, you're not staying ahead. Maybe you start to hear voices because of drug use. Then somebody calls it schizophrenia. And by the time you make 70 or 80 and you're inside of a nursing home, because many family members have died, your kids are possibly sadly not willing to take care of you because of your behavioral issues that are going on, and they can't maintain you inside the home with the other family members. Next thing you know, you end up in a elderly home or a nursing home, and somebody may call you dementia. Now, the question is, if that's the same person, at 3 years old, nobody would have said that was dementia. And of course, at 86 years of age, nobody would call that ADHD. But it's the same individual. And I propose to us that maybe we're looking at the same person, but looking at different developmental times where you're expecting one thing, where we put these diagnoses, not looking always at the long-term outcomes that can occur, because there are similarities. And many times we're making the decision based upon development, because if you were a child acting up in school and you were not hearing voices, not having mood issues, more than likely that person would have later been called schizophrenia, more than likely would have been called ADHD with these certain symptoms without the others at that time frame in life. So we have to look at these early diagnoses and pay close attention and follow individuals and study what's going on between one to the other. And then the diagnostic shifts that occur when we're looking at actual age. So we have to look at innovations in treatment and management, advances in ADHD. It's a lot of newer medications coming out. You're looking at stimulants and non-stimulants, and many with the stimulants, you're trying to get the medication to last throughout the day, but cut off early enough so that a person can go to sleep at night. The non-stimulants work 24 hours a day, but it can take longer to work. Then you also have the digital therapeutics that are out right now. And then don't forget about behavioral and cognitive therapies that can also occur so far as time management, working with families, working with kids, knowing your rights inside of the school, so far as IEPs, individual education plans. And then when you look at schizophrenia, you have your long-acting injectables that are shown to work better than your shorter antipsychotics on average. Also, you're looking at newer mechanisms of actions outside of dopamine. And then, clozaril and clozapine, the issue with clozapine and not being able to get the medication because of the reams, so far as the amount of blood work that is required. The question is, how necessary is that? But also, when you put all these different barriers between the doctor and the patient and getting the treatment, it's less likely for the treatment to occur. And I can tell families this: the more often I see you, the more likely we are to get better. But one of those barriers is that's not enough for me. And there's only 24 hours in a day, and I can only see patients for so long during that in order to keep my focus and attention and be able to do it correctly. So all of these are innovations, but those also with that are barriers, especially when there's something new and I can't even get it to you because the cost of it is so high, and we can't get it to you because the insurance may be refusing to allow you to have it. So far as refusing to pay for it, you can have it, but they're not willing to pay for it. Social and policy considerations, we'll look at stigma reduction. So far as understanding that mental health is very common. Half of the population will have a mental health issue at some point in their life. So we have to combat the social stigma around both disorders. So far as, the child will not be educated or can't do well. The greater majority of my ADHD patients can do extremely well. Now, when it comes to schizophrenia, it's more of a more difficult diagnosis to treat. But I tell families, I don't know how your child will do or how your husband will do or what a wife will do. Let's start the treatment and see what occurs. Typically, most of my schizophrenic patients are doing very well in maintaining inside the home. I have those who struggle a lot, but also have schizophrenic patients who are executives. And people are like, well, how can an executive have schizophrenia? When we look at psychosis, we throw a whole lot of things and say it's schizophrenia, which is probably multiple different diagnoses that mostly has the issue of hallucinations or delusions, but also that social drift issue. But the fact is that if they stop the medication, and when we've tried to stop the medication, they go back to looking very schizophrenic without the treatment. Also, when it comes to these medications, we're always looking for the next drug out. I have families waiting for the next medication to come out because the next medication might be the one for them. So we have to, keep hope alive, educate communities and policymakers on why this treatment is so important, advocate for policy changes, and that we want to expand insurance coverage to cover novel treatments. So the fact is that if I go back to my practice 20 years ago, I can guarantee there are a lot of people who are not going to get help because so much has happened in medicine in 20 years. You got to realize when I came out 20 years ago, there was no iPhone. All right. There was no Chat GPT. So, innovation happens, but I would love it if I had the ability to use all of my knowledge and skills to improve people without so many barriers. And we want to make sure that we're supporting mental health research and funding. There's a lot of cool stuff out there that I can't wait to come to market. I do clinical trials. So I'm like, man, this is something good right here. Hopefully, maybe this will make it out to market, but sadly, without funding, maybe it won't. A lot of innovation. We want to get to it. The barriers to future understanding, so far as getting past the misdiagnosis and developmental levels, understanding that diagnostic criteria do not explain a whole lot of what I see. That is a very good billing book, and it's a very good way to communicate, when it comes to DSM, very good way to communicate to another doctor or another professional what I'm doing. But the fact is that there's so much that happens between these two different diagnoses that, hey, it's not inside the book. And the ability to treat that without as many limits when I'm trying to explain what I'm doing, because the fact is that many times the presentations can be very different. So there is co-occurrence, realizing ADHD is mostly in kids, schizophrenia is mostly in adults. Most ADHD will not become schizophrenia, but we did look at those factors in between that can increase the risk. Drug use and trauma, I would say, are the main two that we have to look out for. Make sure you're supporting the child, and don't make school traumatic because a kid is struggling. You got to realize this kid may be trying 10 times as hard. Your kid who has D's and F's may be trying 10 times as hard as your kid with an A. And we got to make sure that we're supporting that along the way so that we're not further traumatizing the child for the next 12 years regarding school. Look at our research gaps. Let's look at future studies, and we need more people doing this work. In conclusion, there are shared risk factors so far as genetic predispositions for both. Make sure you get the good family history. Neurodevelopmental abnormalities are something that we do every day. I do every day. And sometimes I tell people I've got to just see it over time. And, I tell people this, no matter how difficult it is to treat, every time I give it a try, the chances are that things will get better. Environmental and social stresses, so far as childhood experiences, socioeconomic factors, we can know what to do. But if you can't get it to you, we can't get it to you, what's the point in knowing how to do it? Impact of ADHD treatment, so far as the role of stimulants, there's some thoughts that maybe amphetamines may be increasing schizophrenia risk in kids. I don't believe so. I really don't believe that. I do believe that when we treat ADHD and it's more severe, we may be more likely to use amphetamines. But the fact is that we're looking possibly at something else at a younger age that has to wait for development to occur. We need to research on whether or not we see this or if this is an actual tie of these are tied together. So with this comes the call to action. We need for early accurate diagnosis. We need more integrated care models. It's not all about medication when it comes to people getting better and doing well. Broader access, reduce the stigma. I want to thank you all for your time and attention. My name is Dr. Napoleon Higgins. You can see on the screen on how to find me. So this is my email. You can find me on all the different, I don't know if I'm on X anymore. But LinkedIn, Facebook, IG, TikTok. Well, I don't know how long TikTok is going to be around either. As you can tell, communication is continually developing. So, but you have multiple ways on how to find me. Thank you all so much for your time and attention.
Dr. Higgins, thank you so much for that incredibly informative presentation. Before we get to our Q&A, I would like to quote one of our attendees today who said, Dr. Higgins is so sympathetic, honest, and knowledgeable. Thank you so much for bringing him on. This is very interesting. So,
thank you.
Before we launch into the Q&A, I did want to circle back to our poll question that we asked at the outset of today's webinar, and that was, which of the following treatment protocols for ADHD and or schizophrenia are you hoping to learn more about during today's webinar? And so I will do my best in the Q&A section to come to kind of touch on these. But number one was behavioral or cognitive therapies, with about 19% of people interested in that. And right behind that, brain training. And then stimulant medication for ADHD, non-stimulant medication, and finally, the antipsychotic medication. So launching right into it, I wanted to ask for one point of clarity that's come up in the Q&A. Is it possible for an individual to have a dual diagnosis of both ADHD and schizophrenia together?
I would say I have patients who are diagnosed with both. And so, getting tricky here. All right, so let's go there. When it comes to, so maybe when I saw you, you were young, developmental time went on, we saw schizophrenia. But then also there's the issue of schizophrenia does cause issues with cognition and the ability to think. So now this is, professional stuff to do here. So I wouldn't recommend trying this at home unless you know what you're doing, of which I believe I know what I'm doing some of the time. All right. So I'm never too confident and never boastful, because the fact is that it all is very tricky. So what I've done before is, like, a person has schizophrenia and they're not able to focus and pay attention. So we've gotten the psychosis under control, but we still have this issue of cognition. And I have given people sometimes a stimulant to help with the focus, attention, and locking in. Now, when you do that, you run the risk of worsening the psychosis or worsening the schizophrenia. So you're looking at the balance there, and you want to make sure that you're, well informing the family and the patient of what the possibilities are so far as improvement, but also what is the risk of it getting worse. So we have to make sure that we follow that very closely. So you could have been diagnosed with ADHD first, the stimulant is working. We started something in an antipsychotic. Maybe we stopped the stimulant because the fear that maybe the stimulant was making that worse. But the other side is that maybe you weren't on an antipsychotic, and now we're trying to improve cognition, and we're going to try it with the stimulant. So it is. I do have patients who are dually diagnosed, but realizing that, you're kind of walking on the tightrope when it comes to treatment. But as we talked about in the other treatments and what the question, the previous answers were, cognitive behavioral, setting timelines, schedules, adequate use of a cellular phone. All of those things are very important when it comes to focus and attention and concentration. Digital therapeutics have not shown, as far as I know, to increase the risk of psychosis as well. So you have multiple options on how to improve focus, attention, and concentration, along with being schizophrenic.
Okay, very helpful. So I assume that as a clinician, well, I shouldn't assume. As a clinician, if you do have a patient with both schizophrenia and ADHD, is it typically more imperative to get that schizophrenia under control, and then it's a matter of treating the ADHD in a way, as you said, perhaps utilizing some treatments other than stimulant medications?
Definitely. Okay. So it's important that your trump card is always, one, psychosis. Getting the psychosis under control. That has to be number one. Psychosis, mania, then depression, then anxiety. ADHD is important, but if you're anxious, depressed, manic, psychotic, or high, you're not going to be able to focus. So, the question is, which one do you go for first? My thought is, well, first is safety, but after that, psychosis, the substance abuse, the mania, And then many times as those correct, the other things will correct as well. And if we're still having focus and attention issues, then we try to treat that as well.
Okay, perfect. And you mentioned a few times here digital therapeutics. A number of people asking if you could elaborate on what those look like.
All right, what's out? All right, hold on. Okay, so I guess I can mention brands here. Endeavor RX is a digital therapeutic that is out that has been authorized by FDA. That's the only one authorized by FDA, and I'm gonna keep it there. There is a schizophrenia one that is actually being studied right now. I'm cautious on using apps, especially if you're not using it in combination with a professional who works through these things, realizing that just because it's over the counter or just because somebody gave an app or just because it's X does not mean it's not a therapeutic that could be harmful. I had a young man using Chinese medicine and it was bipolar. And I said, all right, we've been treating you for a while. You're fairly stable. I don't think you should use that. And when I said not use that, not that I had anything with Chinese medicine, but he gave me a list of things that was recommended by his doctor. So I looked them up. I studied them. And I was like, I believe this is about to make you really manic if you do this. And that's exactly what he became because it was psychoactive. So, I would be cautious of using things outside of making sure that you're working with a professional and doing so. But I think there's a lot of good stuff coming down the pipeline.
And I will just make a note that we will provide, for those who are listening, we will provide some links to more information about things like cognitive behavioral therapy, as well as some information about the Endeavor RX that Dr. Higgins mentioned, so that you can kind of research some of these, typically complementary therapies for ADHD specifically, since we do not have time to get into all of them today. But
and the individual education plan at the school, be it no matter the diagnosis, making sure that you're getting your rights met at the school and the accommodations met, because sometimes kids can have difficulty in the main setting that other people are doing, but can do just fine in other ways. So school is an odd place that people have to be for 12 years.
That is at least 12.
Yeah.
Sometimes more, yeah.
More like about 26.
Yeah, gluttons for punishment.
But you were able to choose the other ones, though. Have that you can choose. Yeah.
It makes a big difference. So you did a great job touching on how ADHD treatment, specifically with stimulants, may increase the likelihood of exacerbating schizophrenia. On the flip side of that, do we know anything at all about the risks of undiagnosed, untreated ADHD and how those might contribute in some way?
Well, when you look at ADHD, you can have that downward social drift. So essentially, I had ADHD at 5, parents to get the treatment done. Now I've gotten in 11, 12, 13, 14, 15. Now realize developmentally, once you hit about 13, your peers are more of an influence than your parent. So you start to see your kid come home with things that you never talked about or conversations you never had with them. So they matter more than you. So from about 12, 13 to about 23, who they hang around is going to determine where they're going to go. I tell these kids in college all the time, who are your top 5 friends are going to so determine what's about to happen for the rest of your life. So if you're having these academic challenges and behavioral challenges, you tend to be around more kids who have academic challenges and behavioral challenges as you go into adolescence, which then determines where you end up at adulthood. Now, if you're getting a substance abuse, or if you're drinking a lot, smoking a lot, getting high a lot, especially on a college campus, high and drunk is a high risk of sexual assault, but then also a high risk of violence tends to also occur if you're engaging in those type of behaviors. So as I talked about, the more trauma you have in your life, the more things that happen to your brain, the more likelihood that you have that schizophrenia may pop up later. So I would say that there could definitely be a correlation there that we have to worry about. Now, most kids who don't get ADHD treatment will not end up schizophrenic because most people don't end up with schizophrenia. But what I'm referring to is you're increasing your risk if those other things are happening throughout life as well, be it your decision making or the decision making around with people around you. Make that risk higher. The other thing you have to look at with schizophrenia treatments, though, is that with schizophrenia treatments, and realize, as we talked about, ADHD tends to be a low dopamine situation. Many schizophrenic medications lower dopamine, which not only can the schizophrenia affect cognition, but many of the schizophrenia treatments can also impair cognition. So we have to look at that balance between, your old antipsychotics, your atypical antipsychotics, and then you have some newer things that possibly can avoid dopamine, be it digital therapeutics or other newer medications that are out.
So helpful. Thank you. And of course, you mentioned this in depth in your presentation, but worth repeating that, untreated ADHD can increase the likelihood of those adverse childhood experiences, which can have a further effect on mental health and schizophrenia. And I did want to mention one of our listeners today. Thank you for mentioning. There was a great article in the New York Times Magazine about 1 week ago that specifically delves into Black population in the United States and how and why it is more likely to experience schizophrenia and psychosis.
Yeah, that's a very important topic to talk about. One, you look at long-acting injectables, and getting a shot many times can keep you from getting into other issues and being, recidivism. But the issue of Blacks and risk of schizophrenia in the United States, how much is genetically predisposition by way of the genetic passing down of trauma? And honestly, for example, and I'll say this, kid has ADHD, moved from Canada to the US, mostly affluent white area. Mother was talking about the racial issues that were occurring to her 7-year-old, including the N-word being said. Kid's not willing to play with them. He's had some physical assaults, but it's an excellent school. And she was like, should I stay there with him because it's such a very high reputable school? And my answer to her was, no, you should not stay there. It's highly reputable for who? Realizing that you're 7, now he's having behavioral issues on top of his ADHD that he did not have in Canada that he is having at this new school. He's performing well academically, but socially he's having a lot of problems. I'm like, that's 7 million people who live in the city of Houston, and it's one of the most diverse cities in the country, or some would say in the world. There are too many good schools that you can go to where your child is not going to be called, at least as not as often, or not have to look at that level of racial aggression. And you're going to put him in school for another, 9, 10 years where he has to be around these same type of kids? Of course not. That doesn't make any sense at all. There's too much education going on around the city to be in a situation where that's occurring, because the risk of other mental health issues occurring to that child is way too high. So we do have to look at this issue of racial trauma. A lot of people like to dismiss it and all those kind of things. I'm tired of arguing with people about it myself. I'm like, well, obviously you don't want to hear it. And I can't change a mind that doesn't want to be changed. Or the fact is that, no, you will clearly hear what I'm saying, but you're benefiting from that and you don't want that to change. So this issue is continual and the debate continues to go on. We have a lot more to learn, a lot more to know. And I appreciate ADDitude for the willingness to take on this topic and allow me to do that.
Oh, absolutely. No, we could 100% have a whole webinar just on that sliver. I wanted to read one question from one last participant today. And I don't necessarily expect an answer, but I just really wanted to give voice to this as we wrap up today. She wrote in to say, how can we change the laws to allow families to be able to influence the care that a person with schizophrenia receives? The system relies on mentally ill people to make sound and sane decisions concerning their care. They're at risk for harming themselves and others. It's like standing by waiting for a bomb to go off.
Hey, listen, that's a mouthful. So often in American mental health treatment, we always talk about the individual, but none of these diagnoses occur with one individual. It happens to the entire family. But we're saying the individual is going to make the decision based upon their understanding of where their mental health is at the time. And this is a serious tragedy. I recently got into, doing research. I kind of gave somebody a mouthful about a therapeutic that I'm not sure is going to come out because the protocol is set up to where the family is not included on what's going on with the mentally ill person. The person is in the room by themselves saying what's wrong with them, and of which the illness itself, is part of the perception problem. And so this is a very serious issue that we have to get past, that is causing many people not to receive the care that they need. Realize in America, we have rights. So you have the right to not receive treatment. And sadly, that may be terrorizing your entire home.
Mm. This is such a deep and nuanced topic. And Dr. Higgins, thank you so much. This was an incredibly informative and empathetic presentation. I learned a great deal, and I know that our community members also appreciated your time and expertise on this topic.
Thank you all so much. Appreciate you.
And those of you who are listening, if you would like to access more of the event resources for this webinar, you can visit ADDitudeMag.com and search podcast 532. The slides and recording will be posted a few hours after the live webinar. If you're listening in replay mode, just click on the episode description to get all of those resources. And know that our full library of ADDitude webinars are available as a podcast called the ADHD Experts podcast, and it's available in most streaming platforms. We hope to see you again next week. Our free webinar will be on balancing motherhood and ADHD. To make sure you don't miss any future ADDitude webinars or other information, just sign up to receive our free email newsletter at additudemag.com/newsletters. Thank you again, Dr. Higgins, and we hope everyone has a wonderful holiday season.